A newborn infant presents with severe respiratory distress immediately after birth. I'm showing you a chest radiograph. Describe the findings.
Let me just study this for a second. Right. The chest radiograph demonstrates an endotracheal tube in a satisfactory position. The right hemithorax is completely filled with a large septated lucent mass, which consists of multiple air-filled loops of bowel. This mass is causing a significant mass effect, with displacement of the mediastinum and trachea to the contralateral left side. The right hemidiaphragmatic shadow is not visualized. The stomach bubble is not seen in its normal subdiaphragmatic location. These findings are diagnostic of a right-sided congenital diaphragmatic hernia.
Explain the anatomical difference between Bochdalic and Morgagni hernias, including their relative frequencies and locations.
A Bochdalic hernia is a posterolateral diaphragmatic defect resulting from the failure of the pleuroperitoneal fold to fuse. It is the most common type, accounting for 90% of congenital diaphragmatic hernias, and is far more common on the left side. A Morgagni hernia is an anteromedial defect occurring through the sternocostal hiatus. It accounts for the remaining 10% and occurs more commonly on the right side, as the heart and pericardium provide a physical barrier on the left.
What is the primary differential diagnosis for this presentation on a neonatal chest film, and how can it be differentiated from a diaphragmatic hernia?
The primary differential diagnosis is a congenital pulmonary airway malformation, formerly known as congenital cystic adenomatoid malformation. On plain films, both present as a multicystic thoracic mass with mediastinal shift. They are differentiated by evaluating the abdominal contents. In congenital diaphragmatic hernia, the stomach and bowel loops herniate into the chest, resulting in a scaphoid abdomen with a lack of normal bowel gas patterns below the diaphragm. In congenital pulmonary airway malformation, the stomach and bowel remain entirely within the abdominal cavity, showing normal subdiaphragmatic bowel gas.
Describe the pathophysiology of the respiratory distress in these neonates and the major associated anomalies.
The respiratory distress is primarily driven by severe pulmonary hypoplasia and persistent pulmonary hypertension. The physical presence of herniated abdominal organs in the thoracic cavity during fetal life restricts normal lung development, leading to a decreased number of bronchial branches and alveoli and hypertrophied pulmonary arterial muscle. There is a high association with other congenital anomalies, most notably central nervous system defects such as neural tube defects, congenital heart disease, and chromosomal abnormalities.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this radiograph with prior prenatal obstetric ultrasound or fetal MRI records, which often suspect the diagnosis. I would suggest urgent clinical correlation and advise against bag and mask ventilation, as it distends the herniated gastrointestinal tract with air and worsens lung compression. Formal endotracheal intubation should be performed immediately. I would recommend evaluating for catheter and line placements. Finally, I would document the findings, evaluate the degree of contralateral lung compression, and refer the patient to pediatric surgery for surgical reduction and diaphragmatic repair.